Good morning, everyone. This is Dr. Douglas Fish. I'm Deputy Commissioner in the Office of Healthcare Delivery within the New York State Department of Health, joined by colleagues here, Dr. Heslin, First Deputy Commissioner and Chief Medical Officer for the department, Karen Madden, who will be our lead today, our Principal Investigator on our Rural Health Transformation Program, Mark Hennessy, who is our Deputy Director for the Office of Primary Care Health Systems Management. Thanks for joining us today. We wanted to just take this opportunity to provide an update of where we are with our Rural Health Transformation Program. Karen will be going through some slides here to update the group. This group helped inform the application. We're still in very early stages of this program, but we wanted to get out early to first thank you for your input to help us with our application and to let you know that we were successful with our application to Centers for Medicaid and Child Health Insurance Program services within the Centers for Medicare and Medicaid Services. So this will be a preliminary update. There will be many more updates and communications once we actually have an approved budget with CMS, and Karen will go into a little more details here about that. Also, just some logistics here for the webinar. All lines are muted. What we will do is we're going to rely on the chat to answer questions. We'll have 45 minutes. We will answer as many questions as we can and then can put out an FAQ for any questions we're not able to get to. And this meeting is being recorded, so we will be posting this, I believe, on our website as well. So with that, I'm going to turn it over to Karen Madden and just thank Karen for all of her work here in shepherding this program and helping us get it off the ground. So Karen, over to you.
Thank you, Dr. Fish. Good morning, everyone. I'm just going to share my screen quickly here. Okay, thank you all for joining us today. We appreciate your interest in this program that we are very excited about, and we're very pleased to be able to talk about it with you today. Our agenda for today will be to review the program and the cooperative agreement, talk about our award, talk about what we applied to do in our application, and discuss some next steps with you. We've built in enough time to take some questions at the end, and we ask that you write those in the chat for us so that we can keep a record of all of your questions and develop a frequently asked questions document. So right off the top, we on December 29th received a notice of award from the Centers for Medicare and Medicaid Services in the amount of $212,058,207. We were very shocked and very, very, very happy to receive that award. The year one for the award is actually a 10-month year, and it began with those notices on December 29th and it ends on October 30th of 2026. And this is a 5-year program ending on October 30th of 2030. Just real quickly, some background. I think most people are very aware of this program and kind of how it all rolled out, but just provide some background for you. This is a $50 billion program, which was approved in House Resolution 1 in July. And it's to be paid to all approved states over 5 years, coming out to $10 billion per year. CMS developed a formula for funding so that $25 billion, so the first half of those funds, would be distributed equally to all approved states. All states submitted an application and received approval. So each state is receiving at least $100 million in the first year to do their work. And then the second part of the funding, the second $25 billion, was to be distributed to states based on what we submitted in our application and other certain rural factors that we really couldn't control. So those include the population of people living in New York's rural communities as defined in the notice of funding opportunity, which we'll discuss a little bit in a little bit. It's the proportion of our rural facilities, it's our uncompensated care, our percent of the state population living in rural places, whether or not we have frontier areas, which we do in New York. Hamilton County is considered a frontier area. It's our state area in square miles and our percent of hospitals receiving Medicare disproportionate share payments. So these are all factors, again, that we could not control. They're based on data. I can say that, you know, with with the definition that was used, we have a rural population of 2.1 million people, which is actually fairly high in comparison to other states. So we scored high on that part. We kind of moved down that scale, that list a little bit when we look at the percent of our state population in rural, because we have a lot of people in New York. So we fared pretty well with these rural factors data because, as you all know, based on your interest in this program, New York is a pretty rural state. This part of the funding also was based on data-driven metrics as compared to other states, and an assessment of the initiatives that we propose to do, and then certain state policy actions that the federal administration is encouraging states to undertake. And we received some points for those based on some work that we've already done in New York, and then but we did not choose to pursue all of the state policy actions. And the notice of funding opportunity stated that all applicants should apply for $200 million in each budget period. We did that, and as I mentioned at the top, we received slightly over $212 million. So we were, again, very, very happy to receive more than we requested. Right at the top of our discussions, even before the notice of funding opportunity came out, we developed 4 pillars that we would use to develop our plan. And that was, and those pillars are that anything that we applied to do would have to be feasible, meaning that we would have to be able to complete it within the time period of the program. It would have to be measurable so that we showed, so that we could demonstrate, you know, proven outcomes. It would have to be sustainable so that it would not require further grant support after the 5-year period. And it really needs to be transformative in that we really are hoping and seeking to have innovative change in rural health systems of care. One thing to note that, and we're always reminding folks of this, is that this is not a capital or an operational grant program, and that's not our role. That's a CMS. That's a CMS rule, and it was even in the statute that, you know, funds could not be used for major capital or operations. This list is a list of what the funding cannot be used for, and most of it off the top is pretty common in federal and even state grants. But the thing that we want to highlight for people is that we are restricted in using any of these funds for new construction or to supplant funding for any construction projects that are currently in process or planned. We are not allowed to use the funds for the replacement of payment for clinical services that are reimbursed by insurance, and we are limited to making direct payments to providers of to 15% of our total funding. This is a cooperative agreement. It's not a grant, which it's different. Cooperative agreements require a lot more contact with the funding sponsor. It's very, very high touch. We've already been in touch with our CMS grants management specialist via email and in a call, and we will be having at least monthly, but we're anticipating more calls with them as we begin implementing our plan. We will need to reapply every year for the funding and submit an updated annual budget and have ongoing reporting. Our first cycle of spending is critically important because future budget allocations will be contingent upon the successful spending and, well, the successful allocation of funding in that first period. And unlike many grant programs, this funds cannot be carried forward. So whatever we don't obligate within a funding period cannot be carried over into the next funding period. And as I mentioned, there was a definition of rural that was stated in the notice of funding opportunity. And, many of you probably are aware that there are many, many different definitions of rural out there. And the CMS decided to use the Health Resources and Services Administration's Federal Office of Rural Health Policy definition, which includes some full counties and some partial counties. So we looked at that list and included all of those counties that are fully eligible and those that have 10% or more of their population in rural census tracts or with fewer than 200,000 residents. That came out to 47 of our 62 counties that are classified as rural for this program. And we really want to note that all of our initiatives were designed to address the needs of the folks living in those counties. We, during our application process, we had a stakeholder input process, which I know many of you participated in, and we very much appreciate all of your work and your ideas. We received input from almost 170 stakeholder organizations and community partners, and we used a lot of those ideas to develop our strategy, and which seeks to improve the healthcare access for rural patients and communities through this set of interrelated initiatives to strategically leverage local assets, partnerships, and our statewide infrastructure. We included 4 initiatives in our application, and as I mentioned, they are all interrelated and they all build upon each other by design. They are the rural community health integration, the strengthening rural communities with technology enhanced primary care, rural roots, that's our strategy to build a sustainable rural healthcare workforce, and finally, investments in technology, innovation, and cybersecurity enhancements. So the first initiative, rural community health integration, is based on partnerships, and through this initiative, we seek to establish coordinated rural health systems facilitating comprehensive care coordination. We want to enhance patient access to a wide range of providers across the continuum, and we want to effectively address health and social needs. We are envisioning that this initiative will involve rural hospitals and other providers collaborating with each other to jointly apply for funding and technical support to build or enhance integrated health networks in their communities to meet their needs. We want to note that we will not come to you and tell you what needs we want you to address. We want rural health providers working together to tell us what their community needs are and to submit innovative proposals for us to be able to fund and help you implement. This includes the entire spectrum of healthcare providers, from hospitals to community health centers, long-term care, EMS, county public health, and behavioral health systems. Our next initiative is to strengthen rural communities with technology-enhanced primary care, and I will turn it over to Dr. Heslin to talk about that.
Thanks, Karen. Really appreciate that, and welcome everybody. This is really exciting. So, as we were looking at the whole ecosystem of rural health, we recognize that primary care is really something that is core to the needs of the communities. Recognizing that our rural communities initiative involved the hospitals and bigger organizations that would work together to be able to help build out infrastructure and supporting communities. This portion of the project was to help the providers that are within the community to be able to get to a patient-centered medical home. It's a project that we worked on in DSRIP. About half the practices in New York State became patient-centered medical homes. And we found that those practices actually do better, save the state money, and have better outcomes. Yet we figured out that a lot of the smaller practices, the 1 through 3 or 4 clinician practices, were not part of this project, and a predominant group of them were in the rural areas. And so we elected to move forward with a high-touch, patient-centered medical home model to be able to help those practices be able to get the lift done from being, doing great primary care, but to be able to become recognized through the National Committee for Quality Assurance. In addition to that, we also recognize that while we can't give practices more money, what we can do is help to make them more efficient. And so we have embraced the idea that we could help to embed AI, artificial intelligence, into these practices to help them to deal with gaps in care, building out like their application for medical home, working on patient summaries, helping to make practices better able to provide the care to their patients. And so this is part 2, part 1 being the larger program of supporting the communities and having the communities define what they think is necessary, a process that we built, and this being a more narrowly tailored to embracing and growing primary care. Back to you, Karen.
Thank you. Okay, our next initiative is our workforce initiative, which we are calling Rural Roots to build a sustainable rural healthcare workforce. Through this initiative, we will seek to develop a comprehensive strategy to recruit and train more practitioners for our rural areas through a combined efforts of planning, targeted education, and innovative support. We will have a data-driven approach to identify local gaps in workforce in all workforce areas. We will invest in early career exposure for students and enhanced clinical rotations and strengthen employer-based training programs. We will also be working to expand EMS education through regional remote supported training technologies. We are hoping that this will address both immediate staffing needs and I think even equally, or if not more importantly, long-term care or long-term capacity building. This initiative is really designed to ensure that our rural communities have continuous access and an ongoing cycle of healthcare workforce to meet their needs. And our last initiative is focused on technology. It's investments in technology, innovation, and cybersecurity. Through this initiative, we will be expanding care through telehealth and improving patient outcomes through e-consult. We are seeking to improve care coordination alerts between healthcare agencies in rural counties for emergency preparedness. A big part of this initiative is to strengthen cybersecurity of all rural facilities and to partner healthcare facilities and practices with the State Health Information New York, otherwise known as SHINY, Health Information Exchange, and cybersecurity experts, and to provide technical assistance to providers as they're trying to sort through all of the various ways in which artificial intelligence can be helpful in the provision of care. Let's go forward. Our next steps are to submit a revised budget to CMS by January 30th. We are hoping to submit that early because as soon as we submit that, a 30-day period of review begins. And we cannot draw down any funds until that revised budget is approved. We are continuing to prepare for program implementation and doing lots of work behind the scenes to be ready so that we're ready when we receive approval from CMS. But it's important to note that each time we decide that we want to develop contracts for any activities within any of the initiatives, we will need to go to CMS to receive approval for that. And we will not be able to draw down funds until we receive that approval. That goes back to that point that regarding the high touch model and the communication with them. The year one reporting period end date is July 31st, 2026. So we'll be reporting on what we did between December 29th and July 31st. And that report is due on August 30th. And then we will submit another report for the remainder of the grant period, August 1st through October 30th. And that report is due at the end of November. And that's our presentation. I see up in the corner, there's lots of chats happening. We do have the RHTP at health.ny.new.york or .gov address for you to send questions, and we encourage you to use that. Lots of people are reaching out to us individually, which is fine too, but when you do that, we ask that you also copy the RHTP address just so that we're not missing anything. And with that, I will stop sharing my screen and turn it back to Dr. Fish. Thank you.
Thank you, Karen. Nice job. And there are many questions, and I see Mark has his hand raised. I'll just mention that we will be posting the slides. We will post the recording as soon as we can. It may not all happen today. We have many activities, but the other good news we want to share is that we will be posting the project narrative from the application. So that will give even more detail, including, I think, addressing many of the questions that you see here today, the 47 counties that are listed that Karen mentioned. And also just want to say there's a really good question here relating to kind of existing programs. We did have to be very careful in articulating that this would not duplicate any existing state or federal funds. But what we envision with these partnerships is that local organizations and the applicants that would be applying for funding would be working with these various organizations, the health homes to help coordinate care management, the local county health departments, the certified behavioral health centers, et cetera. And these are all kind of listed in our application and would be partners that healthcare facilities could partner with in their proposals to the department. But Mark, over to you.
Yeah, thanks, Dr. Fish. What I just wanted to mention to folks, and I literally just dropped it in the chat a minute ago, but I want to flag it for folks, a lot of different questions coming in through the chat, is there's a fantastic website where we've already posted some information, which will be also the site where we'll be posting any additional information on a go-forward basis, and that's health.ny.gov/facilities/transforming_rural_healthcare. And that's really the website where you can get good resources in terms of what's going on in New York. Our application, any of the materials that Dr. Fish just talked about, just posted it in the chat a couple of minutes ago. So back to you.
So
Thank you.
So
go ahead, Dr. Heston.
So I was going to address the issue of the question of do we require a state law? The answer is that we do have to meet state finance laws. We do have to meet all the requirements that are part of states for procurement. We have to have an appropriation that will all come through budget, which means that we have to come through in April 1st if budget's on time this year time frame before we can do a lot of this type of implementation. It doesn't mean that we're not working on getting a lot of these projects up and moving and running, but at the end of the day, we still have to go through all of the normal state procurements that are required in order to be able to do this. In terms of the first project, which I think is getting a lot of the questions, the Rural Communities Initiative, we didn't build a project, we built a process. And the process is that communities will identify who they're going to work with within their community. It is required that the hospital, the safety net hospital, be part of that process. That is a requirement. But to the point, any organization can be a partner in that process of how that community wants to define how they would receive funding from this opportunity, and then how that funding opportunity will improve how that community will function. And going back to our original 4 pillars, feasible, achievable, sustainable, all have to be met within that application process. And so those are things that have to be done. And the other complicating factor is once we get that in, we have to run that by CMS and get approval for each one of these projects and every one of these projects that we do as part of this cooperative model. So that's going to be something that happens through all 5 years of this project. And again, each one of these 4 buckets has bucketed money that is going to be attached to it for that year. And all 5 years will have bucketed monies that will be attached to it, which we still have to finish the negotiation as to what those buckets are in general with CMS as we submit our revised budget.
And let me just address, there's a number of different questions that are really sort of related to, will this, and I'm insert name, will this type of provider be accounted for? Will that type of provider be accounted for? A lot of different questions of that kind. There's one from Karen Lepson, for example, which was about long-term care, post-acute care, and I think it says aging services. But so we're not going to answer those questions individually. But just like we did talk about, there will be a frequently asked questions document, which will address all of these questions individually as we go. But really, it's sort of tagging on to what Dr. Hezem was saying a few minutes ago. A lot of the focus is on understanding what the community needs and the prioritization that comes through that feedback and input. So I just want to say we're not ruling anyone out. We're not ruling anyone in at this point. We want to hear from the communities. That's going to help us to moderate and better understand what the approach is through that outreach. So I hope that's a helpful answer, and hopefully addresses sort of a broad swath of questions that are targeted that way.
Very good. So just to emphasize, so after we do, and I think Karen mentioned this, after we have a final coordinated budget, a revised budget for the $212 million, CMS has 30 days to approve that. There may be some requests for additional information clarification. It may take a few more weeks beyond that. So that's why we're early still in the process as we work to get this finalized and approved through CMS. One of the questions that I saw is the goals of the program. I think the goals are really to coordinate care within local communities and the region, partnering with safety net hospitals and organizations that are within the regions. We will be working, on authorities with the legislature for the appropriation of the fund, as Dr. Heslin mentioned, and we will be challenged to spend these dollars and get them out the door in a timely fashion. Each subsequent year's allocation of dollars will depend on the dollars that we spent in the preceding year, as well as meeting certain milestones and metrics that I think Karen alluded to. In the first year, there is, a grace period. It is because it is a shorter year. There are some concessions to allow some additional time for these first year dollars to get out the door and get obligated.
And I do want to emphasize that there are specific preclusions, as Karen said. This is not a capital award. There is some leniency where minor revisions can be done to something, but this is not where you go out and buy a big chunk of capital something. There are some preclusions, obviously, in terms of supporting providers. There are some limitations in terms of how much money can be spent on things like EHRs. So there are some very specific limitations that would be within the grant. And while one project may meet the criteria, you have to remember that we have to do this across the entire continuum of all the projects to meet the overall percentages. And so this is a multi-year work in progress with specific limitations in every year. The question, do we anticipate the hospitals to be lead applicant in most counties? We have not prescribed that. We have not concluded that. And we have said they must be part of the application. They are a large economic driver and supporter of communities in many different ways. But at the end of the day, another organization could be a lead applicant. Again, cautions about particularly things that are state or federal funded already, because we do have to deduplicate money in every single instance, and it cannot be crossed over between. And so that's actually something that was a very, very strict thing. And it influenced how we wrote the application as well, because we were very specifically told when asked, that's a limitation.
I wanted to touch
on
on
a question.
Yeah, let me touch on
Right,
one of the questions I was asked, which is a very thoughtful one. And I just want to start off by saying, I want to be really clear that we see you, okay? What about counties with no hospital? Would they be involved at a regional level with the closest safety net hospital? We've had a lot of internal discussions about this. We want to make sure that this is a state initiative that takes into account both counties that have hospitals and ones that don't. And so we want to make sure that there's an approach that's going to take you into account. And just want to tell you, Christina, who asked the question, we really deeply appreciate the question, and it's one that we've been talking about internally a lot, because we do appreciate the value of counties that don't have hospitals right now, and making sure that they're included in this process. So thank you.
Question for Dr. Heslin. How will the PCMH initiative support practices that are already PCMH certified?
That's great, because what we expect is while the practices that are not will get lifted up, if you will, we expect that we will be helping to embed AI solutions in the ones that are already PCMH certified to be able to help improve how they function. And then there's a third group of people that were PCMH certified that dropped out of the program for one reason or another. And we think that that's a third cohort that we're actually going to work to engage both with some support in terms of getting them back through PCMH, but also with the AI solution as well. Back to the rural community health integration. A lot of people ask questions about, what about existing models and pieces? We fully expect that when we get these applications in, looking for funding for a community, that the communities are going to identify how they're going to integrate those pieces of what the state already supports into how these models are going to become enhanced. The goal is to make these communities more financially and structurally sound. And so we expect that, if somebody has VAP or, has got rural health or has something else going on in their community, we expect that that would be part of how we would see those applications integrate and move forward.
Dr. Heslin, I think a follow-up question from Tracy here. Will funds be allowed to fund collaborations or expenditures of primary care providers with artificial intelligence and or tech companies?
So, don't understand the question, actually. If the question is, are we going to give a practice money to go out and do their own thing, the answer is no. If the question is, Are we expecting that these practices will engage with the tools that we're going to be working with through implementers, facilitators, and things like that? The answer is yes. The one piece that wasn't mentioned in any of this, there is a very small component of the patient-centered medical home project, which is that we're going to work with some practices to help to get them to become ADA compliant within their sites, and that would probably require some small renovations and things like that. So we have a third component to that project as well.
There's some questions related to timeframes, solicitation, review, award, things like that. We're going to defer on questions like that for the time being because, as Karen mentioned earlier, and there was another question kind of touched on this as well. We're still in negotiations with CMS over what this is going to ultimately look like. So some of those questions about timelines are going to need to wait until that gets determined. There's another question that was about the process for selection. Again, those will be determined at a future date because we're still working through what we're doing with CMS, and so we just aren't ready to address those just right yet. Once we get agreement with CMS, we'll be able to more fully lay that out. We are planning and trying to move through that, but again, we've got to wait for final word from CMS, and then we can move forward on that. Anything else you want to say on that?
To Steve Kelly's question, is it going to be a statewide AI system? The answer is no. This is directed towards the primary care practices. And the answer is yes. We're probably going to identify the AI tool that we're going to work with to Tracy's question. The other piece that is out there is that we haven't talked a lot about the third or fourth bucket, which is Rural Roots, as a community bucket of how we're looking at trying to grow communities' pipelines and workforce. Although we haven't talked about it a lot because we focused on the first two a little bit more, the answer is that was one of the number one things that we heard from our stakeholders. And in that particular project, we have multiple buckets of starter programs to be able to help people to develop these pipelines. Some of it's working with the 6th through 12th grade in communities. Some of it will be direct support of organizations to be able to develop pipelines for people to be able to work within their organizations. Some of it will be technology enhanced, like emergency medical services for training, where we use remote learning to be able to help people to train in their communities as very important areas, because while all these things that we're doing are helping to stabilize, if we don't have workforce, then we don't actually get to the next step. And then the final bullet that we talked a very little bit about and Karen outlined is the other one that came up throughout everybody's discussions, which is cybersecurity. Such a critical area as we are seeing us become more technologically sophisticated in how we do what we do, and how everybody's got in the last year we've had multiple cyber attacks. 2 days ago Verizon went out for half a day and everybody was in some sort of issues, and so cybersecurity is a very important thing, which we're going to be working on landscaping the communities and to be able to help to deploy solutions throughout, because this is an area of very, very high risk. And then we're also, as part of the application, and Karen mentioned this, looking at how we connect people through e-consults and through telehealth, building out platforms, and then finally building out some predictive analytics to help communities to be able to think about their workforce and how we think about things. So I think that if you look at the whole application, which will be put out either today or tomorrow, whatever day Dr. Fish, finally is able to get, through all the approvals, you'll see that all the projects are interrelated to each other in one shape, form, or another. We did not define community, Steve, as a county or a smaller subset. Community was something that we simply defined as community. We envisioned that counties would work through counties because of their county public health and prevention agenda plans and the pieces that are already embedded through overall county wellness. And we would encourage people to work across as large an area as possible to be able to support that infrastructure, because that's going to be how we have success. A lot of these communities, are very small. And at the same point in time, it's critical that we get people to collaborate bigger than they did previously, because we need to be successful, which means that we need everybody playing and pulling in the same direction.
I just wanted to address one additional thing. It's a little bit touched on earlier today, but I just want to bring this up. First of all, it's really nice to have you all here with us today talking about this topic. It's really important for us. And for all the folks who thank you, by the way, notes on congratulations to getting this started. I just want to say, this is the beginning of the work. And we're looking for all of you to partner with us as we move forward on all of this. What I wanted to address, though, is, while this is I think a relatively tight group of people who may be considered stakeholders for this process, there's other people who maybe aren't with us here today. If you can extend a hand of courtesy to them about the fact that we'll be posting this presentation and other materials on that website that's in the chat, we'd appreciate it. And we also just want to say that it's possible we may do additional webinars like this for sectors who we couldn't capture here today because of the kind of time frame that we're working with. But we thought it was important to have transparency and give you an understanding of the latest information we can offer about this program. We're very excited to move forward on this, and we want to make sure that everybody stays involved as we move forward. It's a remarkable opportunity for the state of New York. It's a remarkable opportunity for the rural communities who will be participating in this project. It's a remarkable opportunity as well for other partners who may wish to partner with those rural communities to advance health. And so just wanted to address that and make sure that you all knew about that and had an understanding of how to keep people involved. And again, just doubling back on what Karen said earlier, the RHTP at health.ny.gov is the best place to post additional questions, ask any questions even outside of the context of this, get answers, and we'll also be putting together a frequently asked questions document, which I think will further address some of the questions here more directly, and then also continue the communication and back and forth about how this project is going to move forward. And I just also want to say, for folks who are curious, Karen's been leading a team of people who've been working on this. Some of us have been involved. Other people who aren't on this discussion here today have been involved as well. But hats off to Karen, who's really been doing a fantastic job of moving this forward. And so with that, I'll hand it back to Dr. Fish and for final comments, or Karen.
Great, thank you, Mark. I did want to just mention there's a question here about, will funding be used for any capital infrastructure investments related to AI deployment? There are limitations in terms of the rules about capital investments, but certainly there are significant dollars allocated, as Dr. Heslin mentioned, related to artificial intelligence, both within the strengthening rural communities with technology-enhanced primary care, as well as the technology innovation and cybersecurity enhancements. So in terms of the funding disbursements, it's pretty widely distributed among these four initiatives, and as was noted, there's a lot of overlap. So we will be needing to issue requests for proposals to get input and reviewing those. So but all of that is contingent on the approval that we ultimately get for the budget from CMS. And so we just didn't want to get out ahead of our skis here before we get the final sign-off and approval on those dollars. So let me just ask Dr. Heslin if he has any final words before we wrap up, and then Karen, back to you after that.
So just a couple of thoughts. All the questions are great. Some of them we don't have answers to yet because we still have to work with our federal partners. As Dr. Fish said, we still have to submit budget, and then we still have to then negotiate each one of the projects. While we know the general projects that we have submitted have all been in general accepted, the devil's in the details, and we need to still have very detailed discussions with CMS as to how each one of these components of projects are going to be able to be rolled out from their perspective. And then we still have to go through the state process, through the procurement and all the finance rules that we have to meet internally on a really tight time frame. So I fully expect that we're going to have a lot more details about how each component of project will be rolled out, and how each component of project will probably have its own timeline and time frame, and also be interrelated to the other times and time frames. And then we'll redo this every year for the next 5 years because we have to go through this same exact thing on a monthly and yearly basis for the next 5 years as part of the spend. And while I've talked a bunch, and Mark's talked a bunch, and Dr. Fish talked a bunch, Karen is really the person that I'm deeply grateful to, because she's been at the tip of this whole thing and has been coordinating all of us internally, and we'll be working with the team coordinating all of us, the larger us, everybody on this call, internally and externally, and then meeting with our federal people as well. So I'm deeply, deeply grateful to her. Her whole career has been spent in rural health, and now she's gotten everything she's wished for and more, which is that there's a ton of availability of funding to help rural health, and now we have to figure out how to make it count in New York State. And I just have to personally and publicly thanks to Karen.
So Karen, the final word to you.
Oh, shucks. It's a team effort. I appreciate I appreciate all that, but it's definitely a team effort, and it's just exciting for me to see rural health elevated to this level. And we could not have done this without the support of so many folks in the department, including the ones you see here. But we have an implementation team of subject matter experts working behind the scenes. So just thanks to everyone for being here today, for all of your interest in this, and keep the communication coming again. But please feel free to reach out to me individually, but also use that RHTP email address. We don't want to miss any messages from you. So please use that. And just again, thank you for all your interest and for your time today.
Very good. Have a good day, everyone. Thank you for joining us.
Take care. Thank you.
Bye-bye.